Procon challenging the first hour sepsis bundled in hospital acquired septic shock. We have two persons who are going to speak, one on pro and other is contradicting the challenge. First, we have Dr. Dedeepiya V onto the stage.
Okay, so I am going to talk pro on challenging the 1 hour sepsis bundle. How many of you use the 1 hour sepsis bundle? Show raise of hands. Wow, everybody in the audience has risen their hands. So I've lost the debate even before I've begun it. So I'm challenging the 1 hour sepsis bundle using the keywords 1 hour, sepsis bundle, hospital acquired septic shock. So let's look at each of these. First, let's look at it. You begin with the bundle recognition, is it not? So let's look at whether we can recognize sepsis from sepsis mimics in 1 hour. So you'll say that I've made this up, but no, really, I've taken this up from this particular paper from the IDSA, which says sepsis can mimic cardiac disease. It can mimic any of the pulmonary diseases that are being listed. It can mimic any of the gastrointestinal disease that is being listed here. It can mimic seizure, stroke, and autonomic dysfunction of a CNS defect. It could be an endocrine problem. It could be malignancy. It could be a rheumatological problem. It could be drugs. It could be others. In 1 hour, I'm making this decision that I'm differentiating all these sepsis mimics from true sepsis. And then we go to the next part of the bundle, and that is to measure lactate and remeasure lactate if the initial lactate is elevated. Well, this is a bundle. Is there an evidence for the bundle recommendations? Merrick raised the point whether the bundles should be retired, and my answer is yes. Look at the bundles. In fact, for one of the recommendations, there's no study at all. And for the other recommendations, the quality of evidence is either low or at best moderate. But yet, there is a very, very strong recommendation for each of these bundled approach. So, sepsis mimic is very difficult. The bundle evidence is also very poor. And then we go to each of the individual bundles. First is looking at lactate, one, where you see one there is looking at lactate. Okay, let's look at lactate. For me, lactate is only for defining septic shock. Sepsis with persistent hypotension despite receiving 30 ml of kg of fluids, and still the patient needs vasopressors to maintain his blood pressure more than 65 and has got an elevated lactate. That is a definition for septic shock. For me to define septic shock, I need to have an elevated lactate. Well, people guide resuscitation based on lactate. They even measure lactate clearance and claim that lactate increase leads to lactate mortality. In fact, the Survival Sepsis Guideline says I need to guide resuscitation to decrease serum lactate, but they also admit that the evidence is very, very low quality. We all know that lactate production exceeds lactate consumption, and production, in fact, exceeds clearance. And that is why you have hyperlactatemia in sepsis. We all believe that only septic shock can cause lactic acidosis, but look at it. Any of the other reasons, even hemorrhagic shock, regional ischemia, cardiogenic shock, and any of the drugs can cause lactic acidosis. So why are we overemphasizing on the lactate? And we all think that with increased lactatemia, we have increased mortality. Remember, the transient hyperlactatemia does not necessarily indicate a poor outcome, and there's been no direct relationship between lactate and mortality that has been consistently shown. In fact, let's look at this particular study where they aimed to show lactate clearance. This is done in patients who have liver disease, and we know that liver is very important for clearing lactate. On the left hand side, you have bilirubin less than 2, and on the right hand side, you have bilirubin more than 2. You have survivors and dead people. Here in the less than 2, you find both of them cleared lactate similarly. In fact, when you look on the TBI more than 2, you find that among the people who died, their lactate clearance was in fact better. So I can even argue that if you cleared lactate, you could even die more. So it's not very, very consistent among all study groups. Let's look at the other bundle, which is 2, obtaining blood cultures before administering antibiotics. And I don't think so any of us will really argue against it, because that's very, very important. But look at number 3, which is administer broad spectrum antibiotics. And why did this come up? It came up because of this paper by Kumar et al., who said that the duration of hypotension before initiation of effective antibiotic therapy is essential for the survival in septic shock. And this was a study that was done for 15 years between 89 and 2004, when so many other therapies could have changed. It was a non-randomized study, and there was no data presented about organ dysfunction. And this study was supported by unconditional grants from a number of pharmaceutical industries. So, is antibiotic giving early, is it a milestone or a sticking point? I would say it's a sticking point. The Kumar study was a retrospective study. The Ferrar study was a retrospective study. It was an ICU septic shock and mixed study. But then we have the prospective studies from Pushkarik, Bloom, and Haranjik. I'm going to spend a time on the Haranjik study, which is the last one there, which is against the aggressive and the conservative. Look at the conservative group. You find that the conservative group, the mortality was 46.4%. 46.4%. Whereas in the aggressive group, it was 38.5%. I'm not sure whether you're able to see there. This pointer is not. No. It's not working here, pointer. So, sorry. So, if you look at it, what do you mean by aggressive? In the aggressive group, they gave antibiotics pretty much very, very early, and then they de-escalated. But in the conservative group, they gave antibiotics only after they recognized an infection. And this is what you find. You find that if you start the antibiotic in a conservative approach, that is only after you have confirmed an infection, you died less. The odds ratio for risk of mortality in the aggressive group was 2.5 times more in comparison with the conservative group. So early antibiotic also, you don't have enough evidence. And remember that when you give early antibiotics, you give a lot of infection. Among others, you also have a lot of microbial resistance. And importantly, they say if you have shock, you'll definitely have to give antibiotics, and give antibiotics within 1 hour. And it takes more than an hour for me to recognize that the patient is in septic shock. Time to treatment and mortality during mandated emergency care for sepsis. This was a study which says that if you look at individual times for achieving each of the bundle approach, what will be the impact that it will have on mortality? Look at the last line. The time to completion of the initial bolus of intravenous fluids and hospital mortality did not find an association with improved mortality. However, if you take a long time to complete your 3-hour bundle and maybe administer the antibiotics later, you had a high risk of mortality in this particular study. But even in this study, they'll say that their findings are consistent with only small observational studies. But the recent meta-analysis of 11 observational studies showed no mortality benefit of antibiotics given within 3 hours or within 1 hour after the recognition of shock. And therefore, you don't have even evidence with it. And look at this ICU study from India. Among the patients with SIRS with organ dysfunction, 40% is without sepsis and only 60% is with sepsis. And even with patients with sepsis, you find that 15% of them had tropical infections which did not need to have an antibiotic given. So I think that this is only because of antibiotics, you will have Clostridium difficile and antimicrobial resistance. Let me talk about fluid resuscitation. Fluid resuscitation, we said that fluid resuscitation was important because of the early goal-directed therapy, which caused a 16% reduction in ARR. But the PROMISE, PROCESS, and ARISE did not show the subsequent benefit. But look at it, even in all these trials, the median volume was around 2 liters, but the time taken was about 6 hours to administer, not 1 hour. And therefore, we find, I agree that an early appropriate fluid is important, but giving it so much like a bolus within 1 hour is going to be detrimental, as we have seen in the FEAST study, which showed worsened mortality in patients with in Africa. And last would be using vasopressors. I do believe that using vasopressors early on is important, but the time that they made this recommendation, the study even didn't come up. So let's look at what Dr. Sharmili is going to say, other than saying that the Surviving Sepsis Guideline has put it up and therefore we'll have to follow it. I wanted to present evidence to me and tell me why we should do it within 1 hour.
Thank you, Dr. Devi Prasad.
Well, can I get my slides?
Dr. Sharmili Sinha is Senior Consultant Critical Care from Apollo Hospitals, Bhubaneswar. She has a wide range of academic achievements. Her special interests are neurocritical care, polytrauma, sepsis, ventilation, infection control, and nutrition. Again, request all speakers to kindly stick to time.
I'd like to thank the organizers, Dr. Pradeep, Dr. Ajit, and the team Bangalore, and big congratulations for this conducting this mega event. And I'm also immensely thankful to Dr. Dedeepiya for putting forth this literature, which was going to be definitely part of this discussion today. So I heard you at the beginning when you asked a question to the audience that how many would follow 1 hour septic shock bundle. I think you said you were almost lost the battle before you started. Anyway, it was interesting to hear you throughout your presentations. So you have very elaborately covered all the literature that is available, and some of this actually goes in favor of what I'm going to say. So without repeating what you have already stated here, I would like to take you through like what are the distinct or unique features of hospital-acquired septic shock. Mostly this in our setups, these are caused due to this nosocomial infections or extremes of those like hospital-acquired pneumonias, ventilator-associated pneumonias, cortes, collapses, or subtissue infections, or other particular specific device-specific infections which may be possible. Now, how this subset of populations who are in the hospital and now have acquired sepsis to end up in septic shock are different, because these people maybe already have varying degrees of positive or negative cumulative fluid balances. They may be on or already might have received a higher grade of antibiotics. The infections which are likely to cause this septic shock may be or either MDR or x.Dr organisms. And they might have different tubes and pipes in place like the central lines, feeding pipes or urinary catheters, etc. They may be hooked on to various organ support devices like ventilators or renal replacement therapies or even vasopressors therapy. So there is, because of these complex situations, there is actually more possibility of instituting advanced monitoring devices on these patients compared to those who primarily present to the hospital when you do not have these lines or accesses in these patients. Now come to a very common clinical scenario in a hospital. It was a true case. Recently, 62-year-old man who had a traumatic brain injury was difficult to enough, and he was tracheostomized. He was E2, VT, and M4. Then he was shifted to ward with a tracheostomy tube in place. There was a peripheral line and there was a urinary catheter. Around after 3 days, he started spiking high fevers and had hypotension in the ward, for which he ended up again coming back to the ICU. Now, we noted that there was some pus in the urine as well. So, what is the very common presumptive diagnosis in this case? Urosepsis, and in the presence of these clinical signs symptoms, it is a uroseptic shock. Now, I would like to ask my esteemed friend, what would you do, or any member of your team who is guarding this patient, would you do? So, will you not resuscitate this patient? And what will be your approach in this case? Like, would you actually wait? You you presented 2 slides and explaining what are the sepsis mimics. Yes, I do agree there are many sepsis mimics, but sepsis mimics are only a part of, the diagnosis. In a case which presents with this frank signs, symptoms, with this history preceding and following, it's a frank case of urosepsis and septic shock, and these cases more or less is high likelihood having a infective cause for this hypotension and the shock state. So, will you not give fluids to this patient? Those 6 components of the first hour bundle. Will you not give fluids? You know, not send cultures or antibiotics? Will you not start vasopressors if required? And will you not even order for a blood gas to see the acid-base balance? And of course, lactate is a part of it. Remember, blood gas is done just not to look for the lactate. Of course, it comes as a part of the blood gas, but also it gives you many other basic informations like acid-base status, your oxygenation status, electrolytes, even some places if you have the reagent you get creatinine also, and other organ support as necessary. So you cannot leave your discretion or decision planning waiting for the culture reports to come back or the biomarkers to come back, or you have a register or resident in place at 6 p.m. 2 a.m. in the morning to give a call to the consultant saying that what should I do and what I should not do, should I give antibiotics or not. You are very worried about giving antibiotics to your patients who had a very high likelihood of sepsis, especially when they are presenting in septic shock. Mind you, septic shock is a very severe form of sepsis. Severe sepsis form has been totally sent into oblivion in this sepsis 3 definition. So septic shock, the mortality will be very high if you are not waiting for antibiotic not to be given. I am not very big fan of Kumar's study, but there are myriads of studies which have studied the literature if you see. Early antibiotics are definitely a very well accepted and proven therapy. Evidence of grade of evidence, grade of recommendations, you see this SSC guidelines, and there are around 50 to 57 references you'll find that in SSC guidelines, which tells you why early antibiotic needs to be given. Yes, I agree with you. There are sepsis mimics. Suppose this patient, I would say, what could be the possible differential diagnosis? For the teaching of postgraduates, when you teach them, could be pulmonary embolism, could be an obstructive shock, right? And there could be deep vein thrombosis without embolism also. That could be, atelectasis, that could be acalculous cholecystitis, and some, there are myriads of things are there. But those things come later. If you think in this kind of situation, somebody has got septic shock with a history of fever and that is a visible pus in the urine catheter, you cannot hold antibiotics thinking that it will lead to subsequent complications like C. difficile diarrhea or it will give rise to MDR. In fact, one MDR organism may be responsible for this situation in these patients. So I would say it is common clinical sense to administer or to follow the 1 hour septic shock bundle in these patients for the best of patient outcomes. The 6 components I think you have mentioned nicely. So why would you wait for culture reports? Of course, when this patient comes, what cultures will I send? I'll send the blood cultures, I'll send the urine sample, but they will take not less than 48 hours or 72 hours in the best of setups to come back. And if you have a PCRD panel or PCR based panels, not less than 12 to 16 hours to come back. So you cannot hold antibiotics saying that I believe it is not probably septic shock. I'll give fluids, I'll probably build up blood pressure, but I'll not give antibiotics. So that will be something like killing the pressure, and it may be actually sued in the court of law for this matter. Will you wait for biomarkers? Yes, some of this best of setups have got biomarkers. Procalcitonin, we are all a favorite fan of that. But again, it is not available in all places. And even if you send it, not less than 6 to 8 hours are required in the best of places where you have very proactive lab supports. It doesn't come back. So will you leave your team to wander and wait and take decisions after consulting consultants or after taking out making a chart of septic mimics and taking out or taking in, no, I'll not give antibiotics, I'll not give fluids, or I'll not give vasopressors. And obviously for all these things, when the patient comes, you have to follow this 1 hour septic shock bundle. I agree there are exceptions. There are exceptions when they would have developed some complications. They might have large positive cumulative fluid balances. They might have acquired organ dysfunctions during their stay, like cardiac dysfunctions, or they might have acute kidney injuries or liver dysfunctions, etc. In those cases, you can customize, but these are uncommon. And I would say time is essence, as we have heard or learned through our basic learning, that for stroke, brain for this stroke, managing for thrombolysis, time is essence, or for even the heart muscle, cardiac muscle reperfusion also, time is essence. Similarly, for septic shock, time is essence. ICU team composition, remember, varies throughout the day. At maybe 10 a.m. in the morning, you might have a consultant, senior registrar, you have a resident, you have the senior nurse in charges present, but 6 p.m. it may not be so. 2 a.m. in the night, it may not be so. Even 6 a.m. in the morning, it may not be so. So the composition varies. In best of places, a consultant may be in place. Very few centers, if you do a survey in the India, you find not less than 10 to 15 centers will have a consultant, senior consultant in place. Very specific units are there. And I would like to base my practice and my unit to follow a common sense based approach. Because basic clinical common sense, if you apply, 80% of the problems in the intensive care unit can be solved. And same applies to life also. So hence protocols are advocated for uniform practice and implementation for the best of patient outcomes. And since 2001, since this EGDT trial by Rival came out, what it has done in the last 10 to 12 years, it has actually disciplined our approach. Most of the colleagues, when I was a postgraduate that time in PGH Chandigarh, and over the 14 years, what has taught is to use fluid more judiciously, fluid early. Of course, you have to be judicious while you're using it. You need to know when to stop. You have heard all previous speakers talking about process, ARISE and other trials. Why you did not find any benefit from this 1 hour bound fluid resuscitations? Because we had already streamlined our practices so much. We have become so much disciplined that benefit will be always already visible. So this bundle has wide acceptance and application and implementation throughout the world, and in a wide mixture of cases. I would say in intensive care only 95% of patients with hospital acquired septic shock would benefit from this 1 hour sepsis hour bundle. 5% I would say might need customized approach. So take home message will be, it will for general guidance in all kinds of ICU. Of course, I agree that one size does not fit all, but those populations like less 5% of people are less. And remember, common things are common and uncommon things are uncommon. My guide taught us, and till now I follow it and we get positive results out of it. So we must customize approach in patients who have got large cumulative fluid balance, we have got acute kidney injuries, or they have cardiac dysfunctions or kind of nosocomial infections. It is not to this 1 hour bundle is not to promote excellence, but to have some uniform standardization of initial approach to a patient in intensive care unit when depending on the various times of the day. Thank you very much. And I would like to hear Dr. Dedeepiya.
Thank you very much, Dr. Sharmili. You brought across your points very well.